So please put your questions on Slido. I've been just kind of trying to scribble things down as we go throughout the course of the afternoon, and there's so much that would be great to cover. We're running a little bit late, and Mark has said it's okay for us to stay on a bit beyond 5. So given that we're running, I think actually only 10 minutes late now, if we stay on till 5:15 for those that are able to do that, that would be fantastic, and it just gives us a bit more time to make the most of the people that we've got here today. We won't manage to get through all the questions, but what we will do is save all the questions, and then we can have a look through them and pick out the themes and evaluate the things that are burning in people's minds for our follow-up event, which we're very much hoping to have to build further on the conversations that we've had from today. So difficult to know where to start, and it's always a bit of a position of responsibility to pick out questions. But I guess one of the burning ones that's come through in various shapes or forms is around how we resource and enable a workforce that wants to do all the things that it has been describing this afternoon. And Katrina's slide at the end of her talk, I think, was a really useful visual representation of what she termed the inverse medical care law in action, which I think was actually a good way of describing it. Which parts of our medical workforce are growing and which parts are shrinking. If we want to see a tackling of health inequalities, do we not need to see a stronger primary care workforce, and how does that look? And so I guess I would like to ask maybe Bex, first of all, from a kind of UK perspective. There's been a lot of discussion about levelling up, and I wonder whether you feel that we need to level up general practice, and if so, then how do we do that? And then I would like to open it up to the wider panel, if that's okay.
Yeah, thanks, Carrie. I think it's impossible to see how we level up health without levelling up general practice. Certainly south of the border in England, we know that the inverse care law is really alive and kicking. So we've got a big funding disparity between practices in the most and the least affluent areas, about 7% once you adjust for need. And GPs working in the most deprived areas here will be responsible for around 10% more patients on their list. Now, if we add in case complexity and consultation rate, I think probably all of us realise that that is a huge amount of additional workload. So I think it's very, very difficult to see how, unless government address those fundamental inequities in provision of care, you can reduce health inequalities. In fact, and we will again all understand that if you carry on with a basis of inequity, almost any intervention you overlay on that is going to just widen health inequalities more. To come to your workforce point, it's such an important one. I wish I had a great answer, and I don't. Something that we're doing at the Foundation at the moment is looking back at all policies that have attempted to address the inverse care law since 1990 in loads of different domains, including workforce, to see what has worked and what hasn't. Because I think we really have to nail this one. We have to get more workforce into areas of high deprivation, and we have to therefore get people to want to work in those places. There will be lots of folk here, myself included, who really want to work in these areas, but we need to enable more people to feel like that. There are some really interesting things going on looking at how we get more GP trainees into areas of higher deprivation, how we enable people to feel more confident about the work we're doing, how we embed a social determinants focus into medical curricula so that it's more the language we speak. But this is, it's a huge area. I wish I had a better answer. If anyone does, if they can send it to my inbox, and I will relay it to the folk who I know are, to be fair to them, thinking about this in Whitehall, because we acknowledge that it's a big problem.
Thank you, Bex. So answers on a postcard to Bex. Thank you. That's a good widening up of the question, as well as giving us some specific examples of what that means on the ground. I wondered, Noreen, if you wanted to comment from the work of the Short Life Working Group or other policies within Scottish Government, because I know that this has been something that's been discussed a lot in terms of COVID recovery, but bigger than that, obviously.
Yeah, no, absolutely. I mean, I think I mentioned some of the work around the need to train and provide the resource to the current workforce in working in deprived areas, and also how do we attract more GPs and the wider multidisciplinary team to work in deprived areas. But I think I'd just like to pick up on the sort of GP contract element as well, and the funding formula around that. Just picking up on Beck's point there on how resources are allocated. And we have, as a commitment, the phase 2 of the contract, which begins to look at, you know, funding flows and, you know, how that funding going into practices is utilised to better understand, you know, how practices are set up and what proportion of funding is used for income and what proportion is used for workforce recruitment purposes. That work has obviously been paused due to the pandemic, but we're hoping to restart that at some point. But it's an important point. We do need to understand the funding flows to really uncover what the inverse care law looks like in detail in terms of money, and then, you know, thinking about the funding formula. I mean, it is what it is at the moment, and that's agreed between our SGPC partners. But it's certainly something that we would want to look at phase 2 of the contract.
Thank you very much, Noreen. Is there anyone else in the panel that would like to respond briefly to that? Or otherwise, I'll move on to some other questions which are related as well. Katrina.
Thank you. I suppose 2 things for me. One is just that we need more GPs in general. And we've seen the John Gillis report in Scotland, and I think John Gillis is in the audience, but we can look at the GP journey all the way from school, medical school, postgraduate, and see discrepancies really in specialist and generalist training. So I think recruitment and retention, there are lots and lots of things that we can do. So one part of this is getting that right. I think the other part is this extended team, and Noreen's referred to them already, but there's lots of expanded roles that people could have in the extended team. And just, I've talked about the mental health nurses, but if we look at, say, physiotherapists in practice, we know that people in deprived settings will often have high levels of chronic pain. We feel that a lot of our patients who are drug dependent are really self-treating for chronic emotional pain or chronic physical pain. And there's a huge emphasis now on not treating chronic pain with medication, but rather with other approaches. So there's lots of new roles that are there, but we don't have the GPs to train, to supervise. We don't have the premises. So there's a bigger issue around capacity. And just finally, the Pioneer project, which everybody can find on the Deep End website, led by David Blaine, a Deep End academic, just showed that if you really, what they did was, it was almost like a fellowship program, except it was for GPs early on in their career, could stay in a practice, but free up some of the GP partners in the practice, but also really learn more about how to work in the deep end and embed themselves in a practice. And what we found was that not only did those, it was very, very successful, not only did those doctors tend to stay in that practice, but GPs in the Pioneer practices who had been thinking of leaving also stayed. So there's lots of strands to this. Thank you.
Thank you very much, Katrina. There's been some questions coming in about sort of new models of care within general practice and extended teams. And I think, you know, we very much see this as working as part of a team is the only way that we can do what we really need to do for our patients. But I think one of the challenges identified in the question coming in was is changing the culture around how traditionally maybe the doctor has been seen as the answer to every issue, when we know working within a team that we have other healthcare professionals working within the team who can do things if not better than we can. Certainly our physiotherapist within our practice is way better at doing musculoskeletal diagnosis and management than I am. So how do we start to change the way that people feel about seeing other members of the team and not necessarily the GP, and feel confident around that and be able to support these new models of care? I'm wondering if anybody has any thoughts on that. And if not, we can come back to that one, but I'm just looking for hands up. Katrina?
I think Stuart put a hand up, or was that? Or perhaps not.
I did.
You did, on you go.
I'm so
you
sorry.
go first.
You go ahead. I do apologise. Sorry, Stuart.
Yeah, I mean, I think the danger about the expansion of the multidisciplinary team, which is an obvious thing to do. It's not like we've never had them. We've had them for 20 odd years, but it's widening. The big danger is that we reproduce the silos of the healthcare system within the health centre. So the key thing for me is that we fragment care and reduce continuity. And as Katrina, I think, said, from the research evidence worldwide, continuity is one of the few things that we know improves long-term outcomes for multimorbid patients. So I think it's all about teamwork and about having the time to get the team functioning well. And I think the GP does have a leadership role still, as the kind of conductor of the orchestra, because it's only the GPs who have got that wide breadth of generalist education. So I don't think we can just give up and say, oh, it's all to do with, you see the physio, then you see the mental health nurse, and then and there is a danger of that happening if GPs continue to be under such high levels of stress. Because the idea that the expansion of the multidisciplinary team will reduce GP workload is an excellent idea. It's relatively untested. So we don't know if, often you open up a motorway, it fills up. So because particularly in deprived areas, high levels of unmet need. So I think it's a lot about teamwork. And actually, I was talking last night at a thing called the Compassion Salon with Michael West, who's spent his life studying organizations, and particularly healthcare. And, and his work is about compassionate leadership. And I think we actually really need that in action within healthcare systems, and particularly within primary care teams as things expand. And one of the key things here is protected time. And the governorship was a good example. You give GPs a little bit of protected time, they can do the things that they weren't able to do. Part of that in governorship was the multidisciplinary team, joint meetings with social workers and so on, and it worked extremely well.
And a key thing about governorship, as John Montgomery often says, is that it's the only health centre in Glasgow that's never had a problem in filling GP vacancies, because the locums that they've been able to employ have been so attracted by the kind of work that they're able to do there that's where they decided to pitch camp for the next stage of their career.
Yes, so building good teams takes time, because we need to build the relationships within those teams as well. Katrina, did you want to come in there? Because I've got another question that kind of links to that. I wasn't sure if you wanted to come in on that point too.
I think the others have said most of what I was going to say. And I guess the only other thing would be about, we have talked, certainly at the Royal College of GPs, about a national conversation about expectations. And I'm aware, having seen some of the medical press, that there seems to be a feeling that people with low levels of need, who are articulate, who have access to systems, are tending to use their GPs more. So it's for me, part of this is getting people there for the right patients, if you like. Thank you.
Thank you, Katrina. I guess a kind of related question that's come in, and Stuart had mentioned this as well, about if we want to achieve holistic care, we need holistic research, and how do we co-produce that with the communities that we care for, which I think I would be really keen to hear from Darren on, because, how do we make sure that the systems that we think we're designing, that are designed to care for people, are actually meeting the needs of what people need. So I'd be interested to hear from Darren. I'd be interested to hear from Stuart and Bex as well, within your roles around what does good research look like, what does co-production look like, how do we make sure that we're listening to the right voices and being flexible according to the needs of our communities. Thanks.
I'll jump in quickly because I've got children piling in the door now, so I might have to go quite abruptly. For me, a pretty obvious example or that you could use to sort of parallel to this is what's going on with the drug death crisis, and the kind of fatalism that has crept in within communities where this drug issue is a problem. That there is no help, there is no help out there, or that the help takes forever. You have public officials who have went online saying there's no evidence that rehab works, and So when the people who are regarded in positions of authorities are sometimes spouting these falsehoods, then that just kind of solidifies that impression. I think it's worth looking, you know, if we're looking for people in vulnerable communities or who have comorbidity to trust us, we have to look at what do they trust, who do they trust. That might not be people in the positions of authority or within traditional institutions like health. We have a recovery community in Scotland, which is all self-funded and self-governed. There are no experts in it. There are no hierarchies in it. It doesn't receive government funding. And a lot of the recent data that's been published, particularly in the United States, shows a person's got as much chance of getting sober sitting in a room with a bunch of recovered alcoholics a few nights a week as they have with an entourage of medical professionals who are only available from 9 till 5. So I think it's sometimes it's about, I know it can be difficult, especially, you know, doctors, experts are rightly revered, they're highly qualified. They've dedicated their lives to public service, and that does command a certain level of respect. But I think sometimes it can be hard also for us to locate humility. That, you know, and you touched on it earlier, you know, you say sometimes you don't have the answer to the problem. And it must be difficult to say, I don't know. I do not know what to do with you. And you know, sometimes that answer can lie in the community itself. Obviously, I'm not talking about people who have complex health needs. But I went to doctors for years presenting with mental health problems, and no one thought to ask how much I was drinking. I was prescribed Valium, I was prescribed antidepressants, and I don't blame doctors for that. I think we know a little better now that a lot of my mental health problems were actually hangovers, and I just didn't understand. I was an alcoholic at the time. I got that answer in the community, in church halls and community centres. And I think that the answer to creating that trust and that rapport might lie there as well.
Yep, thank you, Darren. And I guess just thinking about a very relevant example of that at the moment being COVID-19 vaccination and trust within local communities about that, and we're seeing you know, varying levels of uptake across the country. Thank you so much for joining us. If you need to go, very, very grateful for your contributions today. Just slip out when you need to, but thank you.
Thank you.
Graham, I see you've got your hand up.
Yeah, it's just a few things. I think, you know, we recognise the added costs of care in remote and rural areas, the added costs of tertiary medicine in highly specialist centres, the added costs of teaching, and something for which there is an added cost but is not recognised or resourced is the added cost of research in populations of the type that Stuart Mercer was describing. He shows us that it's possible to do it, and the reason that it's not done is not because it can't be done, it's because it's not well resourced to do. You know, I mentioned the MRC epidemiology unit in South Wales, which used to get 90% response rates. Well, the research establishment now, if you take Biobank, for example, is satisfied with a response rate of 5%. You know, what about the other 95% of the population? And to go back to South Wales, I mean, the other thing about the Tudor Hart experience was that there was a very active research program going on in parallel the whole time. And it took from the MRC epidemiology unit led by Archie Cochrane the experience that the way to do it was to employ local teams of people who were known in their communities, who weren't researchers from far away. And that was the way to generate very high response rates. But it was done in the context that the patients were helping the doctor because the doctor was helping the patients. So there was a kind of a social contract that was going on, which ethical committees now would prevent. All of that research would not be allowed now because it would be seen as being coercive, that the doctor was using his privileged position to coerce patients to take part in research. And I think to some extent, you know, the focus of research ethics on the individual as opposed to the group has taken us in the wrong direction. So that there are quite, I think, deep reasons why the issue of engagement in difficult to work populations is a problem. But I think there's no question that, as Stuart pointed out, you need to work with streetwise colleagues. Bridie Fitzpatrick was the quintessential streetwise researcher who knew how people worked and how you engaged with them. And the research empires need to employ more people like that and to be much more locally based in order to generate the kind of work that Stuart was able to do.
Thank you, Graham. Harry.
Yeah, so if the question is how do we build relationships with communities and change the communities, I would suggest that the way to do that is to ask them what they want. Many folk will be familiar with the story of Beacon and Old Hill in Falmouth. It was published, the publication was called A Glass Half Full from memory. And this was a community of about 2,000-3,000 people where all the men worked in the Falmouth Naval Dockyard until it was closed. And then over the following few years, it became a war zone. Literally, people were firebombing each other's cars and homes and so on. And it was desperately violent and huge amounts of drugs and alcohol and so on. And it was two health visitors that decided enough was enough. And they put letters through about 50 doors. Here are 50 people who I think might be interested in helping us work out what's going to happen. So they arranged a meeting and 5 people turned up. And over the next few years, the place was absolutely transformed. They asked these 5 people, where do we start? And they said, well, this place is a pigsty. You know, it's the houses haven't been painted for years, the gardens are overgrown. So they started making a visible difference. And gradually, the rest of the community said, change is possible. And they piled in. And there were huge, the local chief constable apparently apologised to them for having abandoned them. You wouldn't often get that happening up here, but, you know, they arranged for first aiders to go out on walking around the place with police. So if they found someone lying down drunk and so on, the guy wasn't arrested as a drunken disorderly. He was seen as a health issue and a problem and discussed, and or you know. So they transformed that place, and they started off by asking them, and that kind of that we need to do more of that.
Thank you, Harry. Bex.
Yeah, it was just to build on Harry's point, really, which is to reflect. And I think things have changed since I've been involved in research, which isn't terribly long, 10 years perhaps, but from a kind of what do we really mean by co-production, and what do we really mean by that old phrase, patient and public participation? And is this a box that I tick on my research proposal to say that I have done it, I've asked someone, I've got a care user working with me, or is this something that I really mean? And what is the frame that I'm going to that person with? Is it, can I help you? Or is it, can you help me? And am I really seeking to understand? And am I really listening to hear? And I feel like if we are really seeking to understand, and if we are really listening to hear, we might get further towards meaningful co-production. And by that, I mean really understanding that our communities can teach us rather than the other way around. I think something I've been interested in recently is the example of poverty truth commissions, which some folk on here will be interested in, know about, and others may want to just have a quick Google, just as a model for seeking to engage with communities in a way that tries to take hierarchy out of it. Because I think I would want to acknowledge that as a GP, we are often seen in positions of power, and if we acknowledge the power that we have and seek to share that and share power with, not have power over, maybe that enables us to get, you know, conversations that are more real and not just a box ticking exercise that I think we probably all would like to see us move on from.
Thank you, Bex. Noreen.
Hi.
And then I've got a couple of questions which come nicely together after that.
Thank you. I was just reflecting on those comments and thinking about the recent report from Derek Feely on the review of adult social care. And what was really striking about that report was that the finance chapter was at the end of it, and actually the patient engagement, people engaging with citizens in a meaningful and constructive way, like Harry said, ask them and they'll tell you, was right at the centre of that report. And I think that is, there's a real political will right now around building on that and ensuring that there's meaningful engagement at policy level. But equally, everyone's responsible for that engagement with our citizens. And Carrie, you'll be aware of Peter Costin and the work that he does around engaging with patients with lived experience, so being at the sharp end of inequalities, bringing them together and providing peer support to each other has been quite powerful, and that voice is being used in the Short Life Working Group. But again, I suppose the question is back to you around practices. I know it comes back to resource and capacity to do that, but that whole concept of community-orientated general practice, how can we move towards that outward-facing role where we ask people what they want and how they want services to be delivered and work in tandem with them? Thank you.
Thank you, Noreen. So I think that kind of links actually to the next two questions that have come in through Slido. And one is from Heather Still, who says, local community plans have shown that a low level of community empowerment is one of the worst aspects of living in a poor area. How can we build on community strengths when there are low levels of trust and little willingness to work proactively with vulnerable communities? So there's something there about it not happening as much as it should, and that making things worse. And then this other question, which I feel is maybe related, which is from Marianne McCallum, who's on the Deep End Steering Group, about how do we support general practice who see their role as beyond the individual care, beyond the care of the individual, looking at those kind of wider sphere type conversations. And because without the additional support and resource required to do that, we're relying on people to kind of go above and beyond, working longer and harder, and or not choose to work in that way. So how do we make it possible for people to engage meaningfully with the communities that they serve without having to put in a 13 or 14-hour working day instead of a 12 or 13-hour working day? Because I think a lot of practices really want to be able to do that. So I know that there are probably no silver bullet answers to that either, but I'd be really keen to hear the panel's thoughts on how do we make that possible. And some of it is about sharing examples of good practice. I would agree, Noreen. So the work that Peter has done, the videos that he and his group have put on YouTube are really powerful, inspiring examples of good practice, which sometimes make it easier to then go on and replicate if you're tired and stressed and not looking to reinvent the wheel. But I'd be keen to hear from the panel thoughts on how we resource and support general practice teams to do that kind of work. And I'm just going to ask folk to shout out because I can't actually see everyone on my screen, so I don't know whose hands are up.
I'm going to say something, Carrie. That's okay.
Brilliant. Thanks, Stuart.
Well, I think Sir Harry's kind of said a lot about this already, but I think it's an opportunity here for the GP clusters. This new part of the contract. They're still fairly early days, and we don't know how clusters are going to work in different areas. But the whole idea behind them is that they'll meet the needs of the local community better. And, they are getting supported by list analysts and getting data reports and so on. But the overriding feeling, and we did a national survey, as you know, 2018, of GP well-being and workload and so on. And we asked about clusters. And the overriding thing is that they didn't think they had anything like enough data support. So they need to get the right sort of data about that. So I agree with Harry that we need that kind of big data made local, but actually also I think there's a real value in getting GPs out and about in the community. I mean, that's what Peter does. It's what we did years ago in a RCGP Scotland project called Living Better, and in fact Craig Miller took part in it, where we were able to give a bit of protected time so that the GPs could go out and meet the local voluntary sector organisations and invite them into the practices. And these meetings were dynamite. They were absolutely fantastic. And GPs who had been working there for 20 years often knew nothing about these folk, because very few GPs who work in deprived areas live in deprived areas. Peter Corson being one exception. So I think there's something, I don't think that takes a lot of protected time, but it takes some. And at the moment, it's not the right time, because I think the GP workforce, like every other part of the NHS, is on its knees. But if the plan of the MDTs freeing up GP time and so on begins to work, then clusters need to be very heterogeneous and actually work locally. And actually, there's no better way than getting out, meeting the voluntary sector, meeting the folk out there, an afternoon a month, and then building from there. And I think that also feeds into this co-production question, which is not just about the research, but about the services. And if you don't get the voice for research, if you don't engage with the actual patients and the practitioners, your research is never going to fly. It's never going to get done, particularly in high definition areas. And folk want to know what difference is it going to make, and does it make any sense to me? So I think the clusters hold promise, but they will need support.
Can I come in? I think that Tudor Hart wrote a paper on the contribution of primary care to undergraduate medical education, and one of the three things it offered was the correction of social ignorance. And I think GPs and doctors in general need to be quite humble in terms of their understanding of how other people live, given that they are by definition a high achieving, well rewarded and anxiety free group in many respects. I just remember when we borrowed Scott Murray's example of community diagnosis projects in Dunby Dykes for medical students in Glasgow, and they were attached to practices that one of the host GPs was the young Alan McDevitt and Clyde Bank, who went on to greater things, and he said he'd learnt more about his community from these students going about watching and looking and observing for 2 or 3 weeks than he had in 10 years of practice. So for many GPs, the first step in looking outside needs to be listening and watching and learning, rather than assuming that they have a lead role. Most of the good examples that we have of community engagement tend to come from pioneering GPs. Tudor Hart was one, did lots in that area that's not well appreciated. I'm thinking, Bromley by Bow in London, Laura Nielsen and the Hope Medical Practice and these are just the well-known ones. There are lots of examples in Scotland that I don't know about that are not well celebrated and valued. So I think that this isn't something that can be done and changed overnight. The challenge, I think, is to identify positive stories and to value them and to share them, in a sense, to normalize them so that other people feel able to go down that path. And I think over a period of time, you build capacity and solidarity. I don't see, William Blake, his quote, he who would do good to another must do so in minute particulars. The general good is the plea of the hypocrite, the scoundrel, and the flatterer. It's very easy to talk the right language. The challenge is to make a difference, and I think it's important to have a practical path whereby we identify what's good, what works, and how we can spread it. So I think that gets back to Harry's idea of a learning system where experience is shared. Can I just put one other thing? And I think that the gold standard measure of whether things are working is the random sample of patient experience, the patient story. What is that actually like to have a stroke in Knightswood or Partick or Possil? Because I think if we had that information, we would find that expectations in some areas are very high and in other areas are very low, and what's delivered is very different. And I think that there's a general lack of understanding of what the random sample of patient experience is. And I think that is a very important bit of information that is hidden because it's not brought to light and it's not shared.
Thanks, Graham. I mean, that would echo a lot of the conversations I think that we've had in recent months and years, hasn't it, around moving from pilots that have been evaluated and have been shown to make a difference to something that is shared more widely. I think making it easy to do the right thing by identifying these examples of good practice, by evaluating them and by celebrating them. Absolutely agree, which has been, I think, one of the things that the Deep End has done so well in the last 12 years. And I know that there's been also a lot of interest in how do we grow a workforce that meets the needs of our populations. How do we widen participation to medical school? How do we cover health inequalities more effectively in an undergraduate and a postgraduate curriculum? How do we get more exposure to general practice so that we have people who are, you know, having their social ignorance corrected, if you like, and more humble in terms of their understanding of what people's lives are like. So
there's a very important aspect of rollout. You know, we've got it for link workers and financial advisors, and so it's important to have the worked example. It's important to have the political decision to put resources in that direction. It's important for the new link workers to have a support system whereby they know what they're supposed to be doing and sharing experience. But there also is a parallel need for supporting the practices who are being asked to work in a new way. The idea that suddenly everyone is going to deliver what Parkhead has delivered with financial advisors is crazy, in the same way that giving a practice a link worker doesn't mean to say they're all going to be like Peter Costin's practice. We know that when you roll these things out, there'll be some practices that take to it like a duck to water. Some will take longer, and some will take a very long time because they're very confused and perhaps resistant to the idea of it in the beginning. So I think that this idea of a learning system, I think, is really important in terms of supporting practices to work in new ways, establishing, because practices don't like to be outliers. So the challenge is to establish norms, new norms that encourage people to go in a particular direction. And it can't be done simply by rhetoric and well-imagined policies. It has to be supported on the ground by relationships in which people share experience and views.
absolutely.
Karen, if I could just quickly comment. Yes, I think the link workers, we always tend to think about linking with patients, but I think it's also linking with practices and learning about our communities, and there's huge potential there. And just very, I completely support what the others have said, but just very briefly, I think there has been some moves elsewhere in the NHS, not really in Scotland, to have a digital approach to general practice. And actually, we've all missed seeing our patients as much as we've had to necessarily reduce our contact with our patients. That's been inevitable. But part of seeing our patients is actually learning about them and learning about our community and being able to respond to their needs better. So just to put in a plea for that. Thank you.
Thanks, Katrina. I wondered if digital exclusion might come up. I would be surprised if it didn't come up, because I think that's something that we've all been acutely aware of in the last 15 months. Is it worsening health inequalities and widening the gap for people who really struggle to use the technology, don't have access to it, don't have access to the private space needed to have the conversation, don't have English as a first language, etc. It has been pretty difficult, I think, for a lot of people. So a lot of thought needed on how we mitigate that moving forward. A couple of questions have come in around continuity of care. That's been, it's something that we hold and value very highly as practitioners, and we know of course that continuity of care reduces morbidity and reduces mortality, but feels particularly important for people who get sicker earlier, live more of their lives in poorer health, have maybe a greater need for relationships of trust and empathy and enablement. And so a couple of questions have come in around whether there is equitable access to continuity across the country, or whether COVID has made that worse, or whether there needs to be provision in the contract to prevent erosion of continuity, specifically by practices being taken over by large practices, so kind of multi practices within Scotland, which I know is still reasonably rare, and is much more common down south. but just concerns around what that does in terms of fragmentation of care, particularly for people who are vulnerable. So I just wondered if anybody had any thoughts on that easy topic as we come to the end of our panel time. Thanks, Stuart, and then Bex.
Yeah, just briefly. I mean, I think we know continuity is very important. I mean, it's in a way it's the heart of general practice, the basis on which the relationships form over time. We're probably with a very part-time workforce. I don't think it's achievable now or in the future to provide personal continuity of care to every patient on the list. And actually, probably not every person needs it. I do think it has to be prioritised for people who need it most, and that's probably people with complex multimorbidity. I think people with mental health problems. That makes it harder in the deep end because you've got more of those patients, of course. And that, in a way, makes an argument for preferential funding of practices working in deep end areas. I mean, there's possible ways around it. If you can't always see the same person, you can have a kind of buddy system where maybe two GPs will see, it's one of two GPs that they'll see. I mean, many practices try to do that. It's often quite difficult to actually operationalize it, particularly if somebody feels they need to be seen quickly. But I do think it's a huge issue, and I think the large super practices that are developing in England, often through the private sector, buying up practices, I think it's a disaster for continuity and for the things that will help the sickest people. I think it might work okay for the worried well or people with minor illnesses, but I don't think it's a recipe for success.
Thanks. Thank you, Stuart.
Thanks, Carrie. I was just going to reflect a little bit of what is happening down south, I think. One is, so Stuart, I would share your concerns about large super practices, but actually quite separate from the privatisation of general practice is the expansion of primary care networks, or rather the implementation of primary care networks in England. So this idea that we are now working as groups of practices, delivering care to neighbourhoods of populations, and all of the additional staff, which were, of course, partly a policy solution to the lack of workforce in general practice, are being shared across primary care networks. So there would be a risk within practice of dilution of continuity of care, but it's not just within practice, it's now right across a network. So we at the Foundation are really interested in what will happen to continuity of care with the implementation of primary care networks, and we funded a team in Manchester, Kath Checkland's team, to do a longitudinal study of that. I think, it's something I am really worried about. The other thing that I'm worried about, just to come back to that first question on workforce and additional roles in general practice, which of course isn't just happening south of the border, is how does recruitment and retention of those roles play out in areas of higher deprivation? The early evidence we have from England suggests that networks in more deprived areas are less able to recruit. So we're going to see a widening of inequality in access as a result of that. And also, are we going to be able to, back to that question of how we support the people coming into those additional roles, do we have the headspace, do we have the time to support those people, to embed them in practice in the way that we need? I think you're quite right, Stuart, there will inevitably be in it a kind of micro team continuity model that needs to evolve around some of our patients. But the impact, I don't know where the balance is here between the need for an expanded workforce in primary care. We clearly need more doctors, but we've been trying for a long time. That's very hard. That needs to carry on. It's not happening. We expand the rest of the workforce. How do we deal with the continuity issue? And how do we segment the population? I guess, to use a bit of a jargony term, but how do we work out who really needs it and how to do it for those who need it the most?
Thank you, Bex. Indeed. Katrina, and then I've got a final quick fire question round, if that's okay.
One of the things we've talked about in our practice is following the NUCA model. So this was a model from Southeast Alaska, and our lead mental health nurse actually went to Alaska to learn about it. And it's very much a healthcare model developed by the community, where they looked at their own needs and their own problems and came up with their own solutions. and continuity is part of that, as is case management. And that was to do with identifying people who may have multimorbidity, may have mental health problems, may be particularly vulnerable, may be terminally ill, and they would have essentially a key worker, a caseworker, if you like, within the practice. And it wasn't necessarily the doctor. So it might be a lead receptionist. In our own practice, we've trained our receptionists to be care coordinators. It might be a district nurse. And they are key to continuity. And people may just be in that system for a while they need it, and then come out of it once they're better or things have resolved a little. So there are models that are suited to deprived areas, but it just needs a lot of work to set up and maintain. So it may be that we can't offer continuity to all. And we know that patients value continuity differently. It's more valued by I think, women and people from deprived areas. If I remember right, Stuart's nodding there, he probably knows. Some people will put access in front of continuity, and we know that too. So it's also getting that balance right. Thank you.
Thank you, Katrina. So it's 5:10. We've just got a few minutes left, and I'd like to just quickly say thank you to everyone as well. So I was thinking it would be very disappointing to think that in 25 years' time we would be having a conference about 75 years of the inverse care law. So if you had one wish or one idea that you would like to see brought forward to reverse that trend, I wonder what it might be, just as a kind of a thought for us to take home at the end of today. And I wonder if I could start with Graham. I'll go in order of speakers, and it would have been Graham coming in first, but for our tech issues. Oh, you're on mute, Graham.
Thank you. I would pick a test of whether we can actually change things, not necessarily the most important thing. But there was Stuart contrasting government support for primary care research in Scotland and England. And it's a gross discrepancy, and it's a huge explanation for why it's difficult to make progress in terms of providing evidence. So, and of course, the reason for that is because there are very entrenched establishments of specialist research who have a more powerful call on research. So that's an example of how the challenge is to wrest resource and possibility from the establishment, because unless we do have examples of challenging the establishment, by which I mean the existing order of power and resource, then we will be here in 25 years' time. You know, unless the establishment shifts in some ways, and that's just one example of what we need to do. The balance of specialists and generalist professionals is another challenge. If we don't address them, then the establishment will, which is the existing order of things, may well prevail.
Thank you, Graham. Harry.
It's easy for me. What we need is an improvement science approach to this. When Derek Feely was chief exec of Scottish Government, he brought in Jason Leach, and we started to learn from the Institute for Healthcare Improvement. We reduced patient mortality in Scottish hospitals by an astonishing amount. We've improved well-being in babies and children, reducing infant mortality and so on. And there is enough really good knowledge as to what works, but what we have encountered is that it's happening in pockets. And we create an improvement science collaborative in which we share the learning. We set down what do we want to change, by how much, by when, what are the drivers of change. And I'm just thinking, very shortly, Jason Leach is going to have nothing else to do, so we might as well get him back into the improvement business and make it happen and collect the data. And I've been speaking to Roger Halliday, the government's chief statistician, about collecting data on this, and he's very positive about it. And what stimulates politicians more than telling them that if they invest a bit of money up front, it will save them a shed load further down stream. Almost $4 billion a year spent in the health service alone dealing with the consequences of chaotic families and difficult life circumstances. And the GPs, particularly the GPN GPs, have shown that they can make a difference in that area. So I would wish for an improvement, collaborative approach to be set up ASAP. Thank you.
Thanks, Harry. Katrina.
Thank you. I guess my last slide was called A New Kind of Practice, Meeting Unmet Need, and I defined it as a deep end practice which was designed, evidence-based, with defined resources and evaluated outcomes, and then mentioned things about generalist care, mental health, clinicians, link workers, longer appointments, care plus appointments would be ideal, and locality-based public health. So for me, a new kind of practice, and perhaps with an enhanced service to support it, but very managed so that we know how well it works, how we set it up, and what outcomes we're looking for. Thank you.
Thank you, Katrina. And Stuart.
Well, you probably expect me to say we need more funding for research, and of course we do. But the bigger picture, I mean, I think I agree with what everyone said, but at the bottom line, we need the political will, sustained political will to support primary care in the way it's needed across the board, but also particularly in deprived areas. It's not a level playing field. And that requires transfer of funding or additional funding. We can't pretend we can do all of this without extra money. And the idea that we can increase the GP share or the primary care share of the budget, you know, from 7% back up to 11%, and that's the answer. I mean, that's just that's only takes us to where we were, and the future has to be much higher than that. I mean, I think back to the CARE report, you know, whatever 20 years ago. I'm not saying we haven't made progress. So it's political will, and I think a lot does come down to funding and reallocation of redistribution of resources.
Thank you, Stuart. I think Darren has had to leave us, so I'm going to go to Noreen. I don't know how politically neutral you're allowed to be, but what would your wish be?
Well, I think my wish is quite complicated, but also in a way simple. It's how do we address the implementation gap? Because you can have the political will, you can have the funding, and I take the point that there needs to be more in that, and you can you really have the support and backing of our politicians, but the implementation gap is where we're falling down. How do we address that? How do we get it out right on the ground? So again, citizen voice in all of this, the human-based right approach has to be threaded through everything we do. Thank you.
Thank you, Noreen. And Bex.
Thanks, Carrie. Thanks everyone for having me. So I would love the implementation route, but I'm a real pragmatist, and I don't see how we solve this problem unless we get equity at the heart of it and proportionate universalism. I think the implementation science has to be put on an equitable playing field, not a level one. So fundamentally, I think we need to work out how you properly create a funding formula that adjusts for need, both and undermet need. And then, and this is the magic one, I really wish I could solve it, what are the political levers and the levers within our own profession that get that funding formula implemented so that we get resource, funding and workforce in proportion with need, not equally but equitably. That's my wish.
Thanks, Bex. Good wishes. Sounds like another conference coming up. So I would like to just take the opportunity to thank everybody, all our speakers from today. So Graham Watt, Harry Burns, Katrina Morton, Stuart Mercer, Darren McGarvey, Noreen Ahmad and Bex Fisher for joining us on the panel. I'd like to give a big thank you to our organisers, as always. These events are very much a team effort, and there's been a huge amount being played out behind the scenes. So a special thanks to Dr. Lindsay Crawford, GP and clinical lecturer in Glasgow University, who has led us on this venture today, putting together what I hope has been and as amazing an event for you all as it has been for me to chair, supported by fellow Deependers Maria Duffy, Marianne McCallum, Stuart Mercer and David Blaine. And also thanks to Leanne Brown from RCGP Scotland for her project support, and to Mark Pentler and Bill for their invaluable tech support during the day today, which is always challenging. So thank you to both of you. And last but not least, a big thank you to everyone who has joined us today, all the people that have logged in. I know that life is very busy and there are lots of competing priorities, so it's great to see so many people who have logged in today to join us. And I guess we've heard lots of things today, lots of food for thought to take away. I particularly enjoyed those last few reflections from the panel in terms of what do we need to see moving forward. I guess we've heard that the inverse care law is very much alive and well 50 years after it was first described, despite the NHS being in its 73rd year, and how do we try and change the direction of travel. We've heard about the importance of having a public health approach, maybe working alongside general practice as key partners in population health. We've heard about the importance of a team activity when it comes to addressing health inequalities, and not just team activity within primary healthcare teams who need time to build these new models of working and understand each other's roles and remits and support, but also team working along with our patients, and what does meaningful community engagement look like and how do we achieve that. And we've heard a lot about how the solutions lie in supporting systems that invest in relationships and continuity and trust and empowerment. So we still have a long way to go to translate the evidence and the practical solutions into policy and action. But I do believe that there is the desire to do that in Scotland, and that we need to work together hard to achieve that and address that implementation gap, as Noreen has mentioned. And a reminder, I guess, for all of us at many points today, that if the NHS is not at its best where it's needed the most, then health inequalities will worsen. So thank you very much, everybody. We hope to have a follow-up event at some point later on in the year. So do keep an eye on our Twitter feed in terms of when and where that will be. We will feed in all the themes and the questions that have been raised today, particularly the ones that we've not been able to answer through the panel, and we'll feed that into what the next conference feels and looks like. As you log out today, there'll be a little prompt that comes up just asking for a very brief evaluation of how you found today, what's been useful. That very much helps us to inform future events. So grateful if you've got a few minutes to fill that in too. So thank you very much, everybody, and enjoy the rest of your week. Thank you.